Hello, my name is Jacqueline Cloos and I'm from the Amsterdam University Medical Center and the Cancer Center Amsterdam. And I was asked to talk about MRD and why it is important for acute myeloid leukemia. As many of you probably know, the prognosis of acute myeloid leukemia patients is still not optimal, especially not for all patients. And one of the major factors that cause this dismal prognosis is the occurrence of relapse. And of course, we have some tools and diagnosis to have a certain risk assessment of which patients are at high risk of relapse. And those risk classifications are mainly based on chromosomal aberrations and mutations. So that's what we know at diagnosis. And then when the patients are relatively young and especially fit, they will get intensive chemotherapy, and most of them will reach a complete remission. This complete remission is based on morphology. So less than 5% of blast cells in the bone marrow as shown by morphology. But that's not a good prognostic marker to see if a person will get a relapse. So there have been techniques now like molecular techniques and flow techniques that we can look more closely at the bone marrow if there is still leukemia cells present. And that's what we call measurable residual disease. So we are measuring whether there are still cells present, and a lot of data show you now that this is highly associated with the development of a relapse. And especially if there are within these residual cells also what we call leukemia stem cells, then we think that those cells might have highly relapse initiating potential. So we think that they are really relevant for this measurable residual disease. So currently, this measurable residual disease is used to tailor the consolidation therapy. So commonly, it is done after intensive chemotherapy. Then we look at the bone marrow and measure the residual disease. And if a person has more cells above a certain threshold, then you might consider more intensive consolidation treatment, for instance, an allogeneic stem cell transplantation as compared to a person who is negative. So that is the most common use of measurable residual disease. But of course, you can intuitively think about other ways to use this residual disease, but a lot of research is needed to be sure that we can use it as such. So for instance, you would like to monitor the whole disease during therapy, maybe on bone marrow, but preferably on blood. So a lot of research is done on that, and maybe even the guiding of the stem cells can be done according to minimal or measurable residual disease. And one interesting aspect is that you might use it as a surrogate endpoint, because now you have to wait on survival to know if a novel therapy strategy would work. And if you could look at minimal or measurable residual disease and see if your treatment is effective, that would be highly beneficial for the patients. One important aspect is that not only the clinical implementation is important, but also to have a qualified assay. So we have this European LeukemiaNet where we have an MRD Working Party, and together with people from Europe and outside Europe, we're doing a lot of research to look at the clinical implementation and have a highly qualified assay. So these are interesting times for AML. There are a lot of new targeted therapies and also immune and cellular therapies, but the challenge will be to find the right biomarkers to select patients that might benefit from these new strategies. And we think that the MRD is a very important tool to lead us to characterization of the assay and monitoring of the disease. So all to future improvements of the outcome of patients with AML, and hopefully it will be in the near future. Thank you for your attention.